pleasure to start the fourth session. And the fourth session will start by a case from my really very great friend, Dr. Alfadda from Saudi Arabia. He will do a combo technique with everything new. So I will give the mic to Amira from our team to present the case, and then we will go directly to Dr. Fadda. So Amira, please.
So for today's patient, we have a 57-year-old female known to have cholangioscopy with large CBD stones, about 2 to 3 centimeters, referred from another hospital after 3 ERCPs were done. The first ERCP showed that a stone that could not be removed, so they inserted a plastic stent. The second ERCP, the stent was removed, the papilla was rated up to 10 millimeters, but the stone was not able to be removed because of how large it was. The third ERCP, there was a duodenal diverticulum with stent in place. Multiple trials to remove the stone with biliary balloon, then BASC not successful, so a 10 by 10 centimeter plastic stent was inserted with good drainage. Today, we're going to do an ERCP using the Endoscopy, Cholangioscopy, SpyGlass, and stone laser lithotripsy.
Okay, so good afternoon, everybody. Can you hear me?
Yes, we can hear you, Professor Buddha.
Okay, so it's a great pleasure to have us in this excellent conference. I've been enjoying the previous cases that everybody was presenting. So as was discussed, this patient had 3 previous ERCPs, and none of them was successful because of large stones. So we are going to perform an ERCP using the brand new Exalt scope, which is a single-use scope, as you can see here. Luis, if you can go to this one, please. This is the Exalt processor here. It's easy plug-and-play scope. It has all the channels required. So after the procedure, you can discard the scope and get a new one. And before I start, I want to thank all my team. Barbara is our assistant head nurse. Adnan, and the audiovisual team, and Faiza, everybody who's helping me to make this successful. So if we can switch to the endoscopy image here, please. Can you see the endoscopy image? Can you, Fauzi?
Okay, yes, Dr. Fadda, okay. We can see the endoscopic.
Thank you very much, Dr. Ibrahim. So as you can see, this is a view of the Exalt scope that we are using. This is not the regular duodenal scope. You can see how clear is the second part of the duodenum structure. And you can see this case has a large diverticulum next to the ampulla. So I think the ampulla is here, where I am pointing at, and there are some food particles here. So what we're gonna do, we're gonna try to go through the ampulla, and we're gonna introduce our wire, do a cholangiogram to make sure that we have these stones. Okay, Adnan, can you advance the wire, please? Luis, I want you to show the fluoro image. Switch to the fluoro image, please. Okay, yeah. So Brahim, you can see the fluoro, my friend.
Yes, we can see it. Yes.
So you can see the scope is a normal position. We don't have to go to the long position. We're gonna inflate our balloon, and we're gonna start injecting to see if there are still the large stones that have been fragmented and went by now. So Adnan is inflating the balloon. As you can see, we are going to inject a dye. So we are injecting. You can see there is a
big stone.
A big stone there, proximally in the proximal CBD, or probably in one of the main hepatic ducts. So this is to demonstrate that we have large stone. What we are going to do now, we're going to use our SpyGlass. Now this might not be a very this might not be a very straightforward case because of the diverticulum. I usually do free cannulation of the SpyGlass, but here we'll see if we can do it or we can use the assistant of our wire to
Yeah.
the duct. Exactly. So we are preparing our spy now, and as you can see, if you can show this one here, the camera, show here. Maybe you can. Yes. So is this clear here?
Yes, yes.
So Adnan is fixing our SpyGlass just below the channel. So we have now 4 wheels, the 2 exalt wheels here, and then we have the 2 SpyGlass wheels down. If you can go down a little bit, please. So these are the SpyGlass wheels here, and these are the exalt wheels. So we
Okay.
are going to introduce our SpyGlass now. Can I have you, Adnan, the spy, please?
Yes.
So, Professor Fadda, don't do any dilation of the sphincteroplasty before putting the spy? You will
That's
go.
an excellent question, Professor Ibrahim. Now, as you know, the spyglass is 10 French, so it's like 3 millimeter. I think in the last ERCP, the papilla was dilated. So I might not need, can you hold this, please? So I might not need Ibrahim to dilate, but I'll try. If yes, I go ahead and dilate. It's very important when you introduce the spyglass to try to minimize the bending of the spyglass itself, so that you
And
will not, yeah,
and
so
the
that you will not
when you do the
resist.
cannulation, you will use more the wheels of the scope itself or the wheels of the spy.
I actually, Ibrahim, use the scope itself, try to keep a bend, and I orient my scope, my spy scope, directly to the papilla itself. I try the best to avoid the wheels, but I'm trying to go here slowly, carefully, okay, through the inferior wall of the diverticulum, and we'll see how it goes. We're starting to introduce. As you can see, there are some contractions in here. So we continue to introduce our spy. I think our spy went in now,
Yes,
as
we
you
can see
can
the
see.
stone. Yes, I can see the stone.
Sure, yes.
Yeah.
Make sure about the CO2, please. Okay,
This is
can
a
you
very
switch to
yes.
the
This is a very
SpyGlass
nice
image?
cannulation. A very
Thank you
nice
very much,
cannulation.
Dr. Ibrahim. I need the irrigation of the scope. Okay, if we can switch to the spy image, please.
We have the spy image. It's very clear.
Enlarge. So as you can see here, Dr. Ibrahim, we are facing a large stone just in the beginning of the cholangioscopy.
Yeah.
So it's very important to handle the spy scope gently and not to overuse it, so that you can use your position. So what I do usually in the beginning, I open the irrigation and I open as well the suction so that it can clear the field. Then I close the irrigation and I keep it to inflate the duct itself. So
Okay.
as you can see here, Dr. Ibrahim, there is one stone here. It doesn't look very large. Can you reduce the light of the spyglass a bit, please? It does not look as big as what it was showing, to be honest, in the cholangiogram. I'll try to do a gentle pass if I can to see if we have any other stones going inside. And as you can see here, we are going more to the proximal CBD, and we're trying to keep our field centralized in the common bile duct. So we are introducing here, and we are going more proximal. This
Yeah, we
might
can
be,
see.
yeah, is a picture clear, Dr. Ibrahim?
It's a beautiful picture. Yeah, we have a very good
Excellent.
picture.
So I'm not sure, this might be the cystic duct on the left side because it's small. So I'm gonna go and see, and it might be the bifurcation of the common bile duct. So by gently moving the scope, you can see that we are trying to go in. So we went in now, and you can see other stone here displayed. And to make sure, we are going to use the
Here.
cholangioscope here. to see where is our SpyGlass is at. So this is the cystic duct, Brahim, as you can see. So the scope is going to the cystic. We performed like 7 or 8 cases of Merizzi syndrome when there were stones in the cystic duct, and we just did a lithotripsy. So I'm pulling back, and for the sake of the time, I'm gonna go to the distal CD stones that we show, and I'm gonna demonstrate in a minute the
EHL.
the laser, Ibrahim, we have.
Okay, perfect.
I do have the laser. I like the laser because it's both of them are safe. So if you can show me this part here, please. So we're switching our camera. This is the Endoyag laser, as you can see here. We are using a single power. We are using 120 microjoule in the beginning, and we are going with 5 shots per second. If this is okay, then we can continue. If not, then we increase the frequency of the waves, Dr. Ibrahim. So it's always challenging because the laser lithotripsy, the fibers are very thin. You have to handle them with care. And
we have Dr. Fadda. We have already Professor Fawzi Malouf connected with us to chair the session. So he's
yes,
here.
Professor Fawzi, nice to meet you.
Nice to meet you, Professor Alfadda. Thank you so much, Professor Mustafa Ibrahim. So please go on with this beautiful procedure. And my excuses, I apologize for the internet connection problem that I had. So no please problem. Go ahead, Professor.
Sure.
Thank you so much.
As you can see, Dr. Fawzi here, there are 2 stones that we saw. I'm introducing, this is one there, which is smaller than the one which is distal. I'm pulling now here, and you can see my large stone coming, which is in the distal CBD. It's very important using the laser to keep a distance between the stone and the laser. You don't want to introduce the laser catheter into the stone itself, because it can give you an engraving effect rather than hitting the stone and fragmenting it.
And Professor Alfadda?
Yes?
Do we need to keep some water between the laser and the stone?
This is a great question, Dr. Fawzi. In EHL, we don't need to do it for the sake of lithotripsy, but for the sake of inflating the biliary system and make the field clear. I usually use laser, I mean water, to make the field clear. So yes. So excellent. I'm introducing my wire now, slowly and carefully, because they are very thin wire. It happened that we have to remove the SpyGlass because of acute angulation at the tip of the scope, but till now we are okay going into the duct. If I can show you the introduction of the laser in a minute. So I am introducing it very slowly, keeping a good linear force in the laser probe itself. And then when it's out, I'm gonna make sure that my field is clear, my spy scope is centralized. Now I'll try to improve my image. You see this happens usually. I'm losing my view now. So I'm gonna go in again, and I'm gonna try to introduce the spy scope again. So I'm getting...
This is a problem with the cholangioscope, right? So
this is a problem.
In order to expose the accessory, need to remove, sometimes to remove all the unit and pass the fiber, the biopsy, forceps, etc. So it's a problem. But the image, very nice images. Congratulations, Professor Alfadda.
Thank you very much, Dr. Fawzi. I'll use the advantage of being out, though, to introduce my laser fiber in a very straight position. Then I'll go with the cholangioscope and the laser immediately to the stone. And
so your SPY out and you recannulate
I
again
did,
with the SPY.
yeah, I did not intend, Dr. Ibrahim, to take it out, but sometimes it slipped, as you can, if you see now,
Yes.
it's getting, I'll show you now my cholangio going out, and you can see the laser now.
Okay.
Here is the
This is
laser.
clear.
Reduce the SpyGlass light, please, the SpyGlass. Okay, so can you see my laser here? Less than the middle.
Yes.
Yes, okay, so I'm pulling it to the tip actually. You can go, okay, and I'm gonna try and go again to the common bile duct using the shaft of the scope more than the wheels. I'll try to introduce my SpyGlass in a shorter position like this, going slowly without injuring the duct. Can you switch to the SpyGlass image, please? Now?
Yes, we
Okay,
can
so
see
we
those
have,
images.
yes, Dr. Ibrahim. So I'm introducing it and I'm flushing it, and you can see the stone in
Yes.
front of me. So I'm gonna introduce the laser slowly here. You can see the laser coming, the fiber of the laser. I'm gonna apply a laser lithotripsy now.
Yes.
Close the suction, please, for now. Yes, so we will start. So we can see that we are trying to hit it. It's hitting slowly. I'll ask Adnan to increase the frequency. So you can see there are some effect of lithotripsy. It's not as good as I desire. So I'm going to kind of increase the frequency and the joules as well. So we are going with our laser now, trying to keep the laser 1 or 2 millimeter distal to the stone, and we'll try to fire now.
We have
So زيد
Alfadda,
الفريكونسي
we
أكثر
have
شوية.
a question coming from the audience about what is the incidence of biliary duct perforation during such a procedure?
Excellent. Actually, according to the evidence, the endoyag lasers is quite safe. Even if you go out of the stone field, you can have a very good results of safety of the biliary wall. So it's a safe procedure in general, and it has no problem. So we are trying to do the SpyGlass again here. I'll make sure that my scope is centralized to the stone itself. So I'm pushing here. Okay, now you can see, Ibrahim, the stone is there, and there are
Yes.
some air bubbles that I'm trying to avoid. I'm getting closer to the stone as this is my desired position, and you can see that some fragments of the stone has already
Started to
been
see.
broken.
Yeah.
It started to be broken, and now I'm trying to introduce my laser lithotripter as well. I tried both the EHL and the laser, and the EHL is easier handling it inside and outside the cholangioscope itself. So we are trying to get our wire. We are feeling some resistance again. So it's always safe when you have a resistance to pull your SpyGlass to get it out of the duct and to try to make sure that your SpyGlass and laser is aligned well.
So just for the audience, make it clear that for EHL you need to have water between the target and the probe, but for laser you don't need it. But for cholangioscopy in general, you need to put some water in biliary tree saline to give you some visualization. Correct?
Exactly. In ESL Fauzi, we try to keep a distance when we hit the waves. For SpyGlass, for laser lithotripsy, we try to make it very close to the duct itself.
Yeah.
Okay.
And there is a question from the audience. Professor Posner asks, what's your preference, EHL or laser?
This is a very
يلا عبد
political
جيبني wire.
a good political question, Fauzi. So I don't know. From my side, I use EHL more frequent. I don't know, Professor Fadda, what you use more frequently?
Cut it.
And
Okay,
why is that, Ibrahim? Why do you have this preference?
No, it's about availability, I think, because we have EHL in our hospital. So I think it depends on the setting of the hospital. So we have EHL in our hospital. This is why I'm using it more and more. But I think it's more about what you have. So
I see. But it's fair to say that the laser unit is more expensive compared to the EHL unit.
yeah. Okay.
So, Dr. Ibrahim, we are again.
Yes, Professor Fadda,
Yes, tell me,
we
please.
have one more minute that you can show us
Sure.
your last fragment before we move to the second case.
Sure. So we are going with the laser now again, slowly and carefully, till we see the laser is going into the field. As you can see, the SpyGlass image, and the stone is a bit fragmented, and we are introducing our laser catheter into the field. So now it starts to appear. Okay, okay. So it is going slowly with some resistance. You have to be very careful introducing it, not to cause a cut in the wire itself. So we are introducing it slowly. If this didn't work with what we are going to do, we are going to dilate the papilla and use a mechanical lithotripsy.
Yes.
And crush the stone and go out. It happened. That can happen. So
yes, I think this is we should have, and this is the message. I think that we should have everything ready when we start
definitely.
doing such procedures. We should have everything ready. So I will ask Professor Malouf to introduce our next